The Extracellular RNA Communication Consortium is an NIH Common Fund program which works to advance the science and research of extracellular RNA. The consortium hosts monthly presentations on a variety of research topics, and I'm pleased to introduce today's speaker, Dr. Mike Silverman from the Cardiac Division, Massachusetts General Hospital, Harvard Medical School. The title of his presentation is Circulating microRNAs and Risk of Sudden Cardiac Death. Mike?
Fantastic. Thanks so much, Matt. And I'm very appreciative to have the opportunity to share the work that we've been doing in Samia Das's lab in collaboration with Christine Albert from the Brigham and Women's Hospital from the predetermined cohort. So today I'll be speaking with you all about circulating microRNAs, inflammation, and sudden cardiac death. So just a brief epidemiology of sudden cardiac death. It accounts for about 1 in 5 of all deaths and about half of all cardiovascular deaths. And so there's almost 400,000 individuals a year suffering out-of-hospital cardiac arrest in the U.S., and about 10% of those individuals will ultimately survive. And so given the substantial mortality and the significant morbidity for the few individuals who do survive, there's clearly an unmet need for further understanding the pathophysiology of sudden cardiac death, and of similar importance, there's an unmet need for more effective prevention of sudden cardiac death. So right now, the mainstay of sudden cardiac death prevention is implantation of implantable cardioverter defibrillators, or ICDs. And right now, clinicians rely on a reduced left ventricular ejection fraction and heart failure symptoms. Unfortunately, most people who end up experience sudden cardiac death don't have a reduced left ventricular ejection fraction. And so they're not actually eligible or don't meet the guideline criteria for this potentially life-saving therapy. On the other end of the spectrum, of the individuals who do have a reduced left ventricular ejection fraction and who actually qualify and undergo implantation of an ICD, only 20 to 30% ever actually need the device. And so what that really highlights is that there's a need to identify biomarkers of sudden cardiac death so that we can more efficiently target and personalize effective preventive therapy. And the ideal biomarker would both reflect and play a role in the pathophysiology of sudden cardiac death. And so the specific aim of our project was basically to evaluate the association between microRNAs and the risk of sudden cardiac death, recognizing that microRNAs have been associated with pathways that are implicated in sudden cardiac death, and that microRNAs have been associated with the less specific cardiovascular death. So in terms of the population that we studied, we performed a nested case control study within a multi-center cohort of patients who had coronary artery disease and a left ventricular ejection fraction of better or greater than 30 to 35%. And these people were followed prospectively for sudden cardiac death. The key characteristics of these individuals was that they basically were people who were at risk for sudden cardiac death, but were not considered high enough risk based on their left ventricular ejection fraction to warrant ICD implantation. And so in total, there were 129 cases of sudden cardiac death, and there were 258 matched controls. And cases were matched on age, sex, race, and left ventricular ejection fraction. So in terms of more specifics about the study design, plasma samples were collected at baseline, so when individuals were enrolled into the study, and patients were ultimately followed for a median of 3.6 years. And we ultimately evaluated the association between baseline measurements of microRNAs and the subsequent risk of sudden cardiac death. So the primary outcome that we looked at was sudden cardiac death, and we called that sudden and/or arrhythmic cardiac death, or a resuscitated episode of ventricular fibrillation. So if someone had an out-of-hospital cardiac arrest, but either bystanders or paramedics showed up and were able to resuscitate them, they counted towards our endpoint even if they ultimately survived. So definite sudden cardiac death was basically a death or fatal cardiac arrest that occurred within an hour of symptom onset, or if there was an autopsy that was consistent with sudden cardiac death. And probable sudden cardiac death was an unwitnessed death or death that occurred while someone was sleeping, but the person had been without any symptoms in the prior 24 hours. And then arrhythmic death was classified as the abrupt spontaneous collapse of circulation without any clear impairment beforehand. And the reason these definitions are important is because, again, we're trying to identify biomarkers or microRNAs that are related to potential pathophysiologic pathways or processes. And the more specific the definition or classification that we can provide, the more likely we can actually identify something related to a specific pathway. And so the third definition, the arrhythmic death, is a fairly specific, less heterogeneous definition of death, and that will become relevant when we start to go through some of the results and talk about some of the implications. So in terms of the candidate microRNAs, so we had chosen 20 candidate microRNAs that were previously associated with cardiac remodeling in a discovery cohort that we had performed RNA sequencing in. We then selected an additional 3 normalizers that had not been differentially expressed between cases and controls in our previous pilot data. And so that gave us a panel of 23 microRNAs. And so just to refresh the population that we were looking at, we had 387 total individuals, 129 cases, 258 controls. 2 individuals in whom the assay ultimately didn't end up working. 33 had significant hemolysis. And so we ultimately had 352 total individuals, of which 118 were cases, 234 were controls. When we look at the microRNAs that we ultimately ended up analyzing, 2 of them were below the limit of detection, so we ended up removing them from our analysis. And that gave us a total of 18 candidate microRNAs that we evaluated in the 352 individuals. And so how did we measure the microRNAs? We used a multiplex assay called the Fireplex assay from ABCAM. So once we had all of our data, we then performed analysis using conditional logistic regression for 118 cases and the 234 controls. So using all of the cases and controls that we had for the sudden cardiac and or arrhythmic death outcome. We then looked at the association between cases and controls according to microRNA levels. And we did that by looking at whether or not the microRNAs were above or below the median. We also did this looking at microRNAs as continuous variables. And then as I mentioned that the specificity of the outcome may have implications for potential pathways because, again, the less heterogeneous the outcome, the more likely that we could find something related to a pathophysiologic process. And again, the process that we were looking for was electrical remodeling, or something that would manifest as an arrhythmic death. And so that's why the 58 cases of arrhythmic death may allow us to gain more of a pathophysiologic understanding of some of these specific pathways and microRNAs. And so we also did conditional logistic regression for the 58 cases and the matched controls, and again looked for the association between cases and controls according to microRNA levels, whether it was above or below the median. And we also looked for the association between cases and controls according to microRNA levels as continuous variables. So in terms of the overall cohort, basically the average age was right around 65. 1 in 5 were women. An overwhelming majority had previously had a heart attack. About 40% had previously had diabetes. 1 in 4 had heart failure symptoms. About 80% had a history of high blood pressure. 1 in 5 had a prior history of some sort of atrial arrhythmia, such as atrial fibrillation or atrial flutter. About 10% had a family history of sudden cardiac death. 14% were smokers. Most of the population was white. Most were, or I should say the average BMI was 31, so many people were overweight or obese. The average ejection fraction was 47. And as a reminder, we consider anything greater than 50 to essentially be normal. And in order to qualify for an ICD, the ejection fraction is usually less than 30 to 35%. So again, these participants did not qualify based on their ejection fraction for a ICD for prevention of sudden cardiac death, and they were followed for a little bit more than 3.5 years. So when we looked at the risk of sudden cardiac death, and again, this is the entire cohort looking at the sudden and or arrhythmic death using all 118 cases and all 234 controls. And so what we identified was that there were 2 microRNAs that were associated with the risk of sudden cardiac death even after adjusting for a prior heart attack, heart failure symptoms, and a history of diabetes. So microRNA 150 was associated with 1.75 increased odds of sudden cardiac death if the levels of miR150 were above versus below the median. And as you can see below it, miR29A had a very similar 1.77 increased odds of sudden cardiac death if the values were above versus below the median. And then we decided to look to see, well, what happens if individuals had both microRNAs that were above the median? Did that matter at all? And so when both microRNAs were above the median, individuals had an almost threefold increased odds of having a sudden cardiac death event. Then we said, well, there was one more microRNA that was borderline non-significant. So the p-value was less than 0.1, and so we said we would include that in there, and that was microRNA 30A. And microRNA 30A, in contrast to miR-150 and miR-29A, was associated with a lower risk of sudden cardiac death if the values were above the median. And so it was about a 0.66 odds of sudden cardiac death with higher levels of microRNA 30A, although again, not statistically significant to a p-value of 0.05, but we chose to include it because it still was less than 0.1. So when we put all three microRNAs into a biomarker score, and we did that by calling them favorable versus unfavorable. And so if microRNA 150 was above the median, it was considered unfavorable. If microRNA 29A was above the median, it was considered unfavorable. And if microRNA 30A was below the median, it was considered unfavorable. And so we put them into a score, as you can see on the bottom of this figure, with just one microRNA that was unfavorable versus none. It was a non-significant 25% increased odds of sudden cardiac death. But if you had two or more microRNAs that were unfavorable, you had a greater than threefold increased odds of sudden cardiac death. And then if all three microRNAs were unfavorable, then you had an almost fivefold increased odds of sudden cardiac death. And you'll notice that the confidence intervals are fairly wide, particularly as you get to the higher biomarker score, just because the numbers start to get pretty small. So then, beyond looking at above versus below the median, we wanted to see what was the risk according to microRNAs, but when we looked at them as continuous variables. And so when we did that, miR-150 was the only one that was statistically significant, with about a 1.4 increased odds of sudden cardiac death per unit increase in level. And that was a p-value of about 0.03. So, as I mentioned, this is now looking at the broader term of sudden cardiac death. But what we wanted to see was what would happen as sort of a mechanistic validation if we said, well, let's focus on the smaller number of patients, but who had the more specific outcome of arrhythmic death, which is less heterogeneous and more likely to be related to electrical remodeling or some sort of arrhythmia, which is, again, a much more specific phenotype that we might be able to relate to more specific pathways. So when we looked at the risk of arrhythmic death according to microRNA level as above versus below the median, we saw that miR-150 was associated with a near fourfold increased odds of arrhythmic death with a highly significant p-value and reasonably small confidence intervals given the small sample size. Even though miR-29A was not statistically significantly associated with an increased odds of arrhythmic death, there was still a trend towards being associated with an increased risk of arrhythmic death. And we wanted to see if the same sort of combination that had been associated with a significantly increased odds of outcome in the broader population would still predict or still be associated with arrhythmic death in this smaller population. And what we saw was that if both microRNAs were above the median, there's an 8-fold increased odds of sudden cardiac death with a reasonably significant p-value of 0.002. And again, this is all adjusted for a previous heart attack, heart failure symptoms, and history of diabetes. So then, similar to what we did for the broader cohort of sudden cardiac death, we wanted to see, well, what if we brought in the same risk score that we had and applied it to the more specific outcome of arrhythmic death? And so again, as a reminder, if miR-150 was above the median, it was unfavorable. If miR-29A was above the median, it was considered unfavorable. And if miR-30A was below the median, it was considered unfavorable. And so, again, on the bottom of the figure, you'll see if the microRNA score was 1, meaning just one microRNA was unfavorable, a non-significant 4-fold increase in odds of arrhythmic death. But if your microRNA score was 2 or 3, you had a 16 to 18-fold increased odds of arrhythmic death, both of which are statistically significant. But the key caveat here being these confidence intervals are extraordinarily wide, and I think it represents the fact that the numbers here are extremely small. So then we took a step back and said, okay, well, let's see if miR-150 is related to arrhythmic death when modeled as a continuous variable. And again, similar to the more broad population of sudden cardiac death, miR-150 was related to arrhythmic death when modeled as a continuous variable, with about a 2-fold increase in odds per unit increase in miR-150, with a fairly significant p-value of 0.008. So then we took the next step and wanted to see, well, what are the possible ways that some of these microRNAs might be related to these outcomes? And there's, as I mentioned, previous data suggesting that some of the microRNAs have been related to inflammation, fibrosis, pathways that have been previously related to the outcome of sudden cardiac death. And so in prior mirroring models, miR-150 was shown to be related to IL-6, IL-10, MCP1, and TNF-alpha, all 4 of which have been in one way, shape, or form related to certainly cardiovascular outcomes, and in most cases have been related to sudden cardiac death or worsening heart failure. So what we wanted to say was, could we try to look to see if some of these cytokines might be related to either miR-150 or miR-29A? And so in a very small subpopulation, in a very exploratory analysis, we identified 57 of the arrhythmic death cases that had a small amount of extra sample that we could use, and then we found some matching controls, and we measured the levels of these cytokines in a multiplex assay. And so when we looked at the correlation between miR-150 and IL-6, IL-10, TNF-alpha, and MCP1, we actually found a modest inverse correlation between 150 and the anti-inflammatory cytokine IL-10. We also then looked at miR-29A and the same 4 cytokines and saw that 29A also had a modest association with IL-6. So sort of showing that 150 was inversely related to a potentially anti-inflammatory cytokine, and 29A was directly related to a pro-inflammatory cytokine. And so then we said, well, recognizing that the numbers are quite small, we wanted to see, well, are these cytokines maybe related to arrhythmic death outcomes in our cohort, with the key caveat being incredibly small numbers and an extremely exploratory analysis. And when we looked at IL-10 levels, whether it was above or below the median, there was about an odds ratio of 0.25 for the risk of arrhythmic death. That was a nominally significant p-value of 0.0396. We then did the same thing with IL-6, and IL-6 levels that were above the 75th percentile were associated with a greater than 3.5-fold increased odds of sudden cardiac death compared to individuals with an IL-6 level below the 75th percentile, with a p-value of 0.021. So, in summary, what we found was that in patients with coronary artery disease and a relatively preserved left ventricular ejection fraction, we identified 2 microRNAs that were each associated with sudden cardiac death risk, even after adjusting for other risk factors. And that when we used a multi-microRNA biomarker score, these microRNAs were associated with a graded and increased risk of sudden cardiac death that was independent of our gold standard risk factor, left ventricular ejection fraction. And that one of these microRNAs had an even stronger association with the less frequent but more specific outcome or phenotype of arrhythmic death, sort of serving to some extent as a mechanistic validation, and that using a multi-microRNA biomarker score, these microRNAs were associated with a graded and increased risk of arrhythmic death, also independent of left ventricular ejection fraction. And so microRNAs have the potential to serve as prognostic biomarkers and also may provide a platform for gaining mechanistic insight. And that these microRNAs may have the potential to help guide decision-making for preventive therapy for sudden cardiac death, and particularly may help identify individuals who are most likely to benefit from ICD implantation. And so I'd like to thank everyone in the DAS lab, Tony Rosenzweig at MGH, Christine Albert, Morathi and Neil Chatterjee from the predetermined study, the funding sources, and thank you all for listening. And I'd be happy to take any questions.
Yeah, thank you, Mike. Very nice talk. Mike, you may have mentioned this, may have missed it. So how are you doing the sampling? Now you're taking plasma samples, but are you periodically you're taking samples, or?
So the samples were collected from patients when they were initially enrolled in the study, and it's basically a multi-center NIH-funded study to basically follow patients who have coronary disease and are considered at risk for sudden death, but not high enough to warrant ICD implantation. And so patients are enrolled in the study, their demographic and medical histories are obtained, and at that visit, they get their blood collected and processed, and those are serving as their sort of baseline samples. So these are samples that are obtained once at the beginning of the study, and then they're subsequently followed on average for 3.5 years.
I see. So there's no, okay, so it's a one-time collection.
Exactly.
Just a reminder, if you're not speaking, please put your device on mute. There's some background noise. Thank you. And so I guess part of what I was thinking is, so this is a potential marker, you know, obviously if it's sudden death, so you've got some data here that suggests these are interesting. How would these be applied, you know, given that it's, because the question is if you have this marker, if I'm understanding right, you have this microRNA expressed, but maybe you don't have a heart attack for 3 years. You see what I'm getting at, or how would you apply it?
Yeah, so you mean clinically how might you go forward with this?
Right, I mean, how would you, yeah, exactly.
Yeah, no, it's a fantastic question. So I think the next steps for the first one would be this was done in a case control study. We'd have to look at this sort of in a bit more of a larger prospective population. But then in terms of how you might envision using this is, let's say you're seeing a patient in clinic who has previously had a heart attack or has some form of coronary disease and has a mild reduction in how well their heart squeezes. So their left ventricular ejection fraction is 45%, so just below what we might consider normal, but certainly not what would be considered high enough risk by current guidelines to undergo ICD implantation. Now, we know that those patients are at risk for sudden death, but again, not currently considered high enough risk. You might envision saying to that patient, let's check some blood. You look for these microRNAs, and you could basically look at a certain score and say, okay, this person's risk is, you know, substantially elevated, and say even though you don't meet criteria by one metric, we might envision saying this could modify the decision-making to put an ICD in someone who might not otherwise be considered for that. But I think, but to get to that point, we would need to do a prospective randomized trial, I think, before people would be comfortable putting ICDs in people who don't currently meet criteria.
Right. Thank you.
Absolutely.
Okay, well, there's no further questions. Mike, thank you. And again, I'm sure Mike would be happy to take any questions via email. You can find his email either on Jimbury Commons. Do you have it on your slides, Mike, or you just want to mention it?
Sure. It's mgsilverman@mgh.harvard.edu.
Okay, great. All right, thanks, everyone, and thank you again, Mike.
Thanks so much, Matt. Take care.